Welcome back to Beyond the Stats. In this episode entitled Adults in Essence but Not in Mind, we will be exploring adolescent mental health. We will be learning of M.A.N.I, as well as its founder, Dr. Victor Ugo. M.A.N.I, or the Mentally Aware Nigeria Initiative, is a non-profit organization which focuses on improving mental well-being amongst young people in Nigeria. The man behind the mission and vision, Victor Ugo, often mistaken for Victor Hugo, he will say, is a retired clinician, a public health practitioner, a mental well-being advocate, and founder of this brilliant NGO. So over the next couple minutes, we will hear about how he harnessed the power of his story, as well as how M.A.N.I uses data-driven and community participatory research approaches to advocate for mental well-being services for young people living in Nigeria. Enjoy. So, Victor, I've just given the audience a teaser. Now, why don't you tell us more a bit about you and M.A.N.I?
Where do I start? Anyway, so I'll probably start with M.A.N.I. Or just maybe about me. I am Victor Ugo. I'm usually confused as Victor Hugo, the poet.
Yes.
But I'm not him. And I have a background in medicine as a clinician, but I'm retired now. And my work is in mental health. More, I would say probably public health and mental health. I founded my Mentally Nigeria Initiative, which is a non-profit organization that's focused on building a community for young people in Nigeria to have a space to talk about their mental health and learn and grow in the conversation. And I've been doing this for the past 5 years plus now. And M.A.N.I started up in 2016. Okay. And I think I've said this like so many times, is that M.A.N.I started from my own experience of a mental health condition while I was in medical school. I was very, very privileged to have a good support system, have very good friends who were exposed. It was different from the typical Nigerian community where if you tell your friends that you have a mental condition, you probably won't feel safe enough to keep on having that conversation. But I had very good friends who they were with me for some of my therapy sessions. They took me to the hospital, so sometimes it was very, very supportive. So I kind of thought that was a typical thing. I thought that was normal. But I think what changed that perspective was after visiting a psychiatrist, and he sounded very surprised. It's like, you're a doctor, and it's like, it sounds surprised because he has just finished looking at my diagnosis, right? And he just finished changing my meds and giving me more meds. So he was like, "You're a doctor? Wow, okay. How you got diagnosed in medical school? How did that happen? Nigerians don't mind their business."
Oh no, we do not mind our business. No.
I was like, it's like, you're very lucky. I didn't take that in a very light, manner. I was like, what do you mean? I didn't tell him, of course, he was an older man, and obviously they have to be subservient and respectful. But when I left that consulting room, I called my friend. I was like, can you imagine this, typical Nigerian situation where this guy is telling me I'm lucky after giving me 3 more medications to take? I didn't feel lucky, of course.
Of course, yeah.
And, of course, my friends are like, report him, don't go back there. Very supportive as usual. But then I called my mom and, of course, did the same thing. And then she was like, I get where you're coming from, but have you ever considered, this is basically my grounding session. Like, have you ever considered, even in your school, which is like a private university, closed space, all of you are from rich homes, like, you had classmates that dropped out of medical school. And remember when you told me that some of your classmates, like, you had 2 classmates that actually killed themselves? the same year you got diagnosed. So I was like, okay, that's a different perspective. And I decided to explore that. I decided to explore that perspective. And I went online. I was looking for mental health organizations that I could volunteer in. I could volunteer and give some of my idea, some of my experience, because I've always been interested in public health. I've always taken, when I was medical, I was taking courses at Yale, public health. I was taking online global health education courses. I was just, I learned about communication and advocacy. I was doing all of that. I was like, I'm gonna give my expertise to any organization I find that's doing stuff on mental health, the way that I want to see it. And I went online. I found a couple of them on Facebook, but the last time they posted was like the previous October. So it's like, how it was like about 6 years ago in Nigeria. It's an October by October thing. Mental health awareness was only in October. It's like World Mental Health Day, World Mental Health Week. Then you find them going on rallies, not rally, they just go on a walk. There's only psychiatrists, majorly psychiatrists that organize it. Or you find them doing a symposium in the university. And I was like, if I was a young person, would I go to this place? Like, do I find myself going to sit down for 2 hours for public health, for public lecture? I wouldn't. I hated it. So I was like, yeah, this is not exactly how I would want to run my own organization if I had one. So of course I started thinking about, maybe I should just register an organization. So 2015, December 31st, I got the organization registered. I basically blackmailed my friends to join in as directors. Because before you register as an organization, you have to like get people to join in as directors.
That's right.
I was like, you guys have to do this with me. I don't know like what else I'm gonna do, but I want to do this full time. Are you sure? I was like, yeah, okay. They came on board. And for the 6 months before we properly launched, it was a time of learning and unlearning and trying to get more supporters that I can have as a core group. And that's how we started.
Okay.
So we focused on awareness initially. It's like anti-stigma awareness. It's like very do not very, should I say, very enthusiastic about people not discriminating against people with mental conditions, or people not being not stigmatizing against people that have those mental conditions. And I was very happy to tell my story over and over again. It's like I have dealt with anxiety and depression. I have attempted suicide more than 3 times before I turned 20. It's like I was happy to tell that story. I was going to radio shows. I was pitching myself to radio shows just so I could tell my story. It didn't make sense to them because it's like this is a story that people are usually afraid to tell. But you are currently pitching to us that you want to tell the story. But what that did was that, and it's normal now, I understand it, is that when I was able to share my story, I could easily find other young persons who could see themselves in me. Like I'm this person, I'm this young. I was in medical school, or I was in school, and I struggled and I dealt with so many different things that stressed me out, but I didn't know what it was. And they started telling their story. So we actually found a group of people who were happy to tell their own stories. And that's exactly how we kicked off. But that started changing because our focus is on young people. And we thought, how do we create something that young people would be interested in? And let me tell you, before I knew what co-production was, I thought it was going to be a good idea to actually get young people in a room and ask them, how would you want me to do advocacy to you about mental health? And so in October 2016, we had about 300 young persons in Lagos come together. I can still remember that was like our very first event. I was so anxious, I was like, is this going to work? But this was after 3 months of like online campaigns, like begging celebrities and influencers to retweet my tweets. It was so pushy. It's like we pushed it. And for us to get 200 people to actually come, the approach we used was, what are we going to do to get people to come to a particular place and enjoy themselves and contribute to the discussion, help us create our own strategy for what this organization should do. So we did, we held an event, we called it Eat Out to Reach Out. Yeah. So basically it was food, right?
Food. Did you have jollof rice? Did you have jollof rice?
And it was like all of it. We had vendors come with their own food. We had some of the food that was free for everyone that came to eat. We had TVs at different spots. You know, we had to rent TVs at different spots. It was a very nice restaurant. And we projected to those TVs our PowerPoints that was, you know, asking questions and gave them cardboards to answer some of the questions. And so it's just like we were co-designing the programs together. Some of the questions difficult questions that we had, some of the assumptions that we made that were wrong, you know, it was a very helpful time to unravel them. And basically that gave us the direction that we wanted to go. So from November, we from what we heard, is like we need someone that was going to be consistent, someone that's going to explore mental health from a non-jargonistic perspective. You know, it's like, don't tell me about schizophrenia. I don't know what that is. You know, that's a Western term. Tell me about hearing voices. Okay, like I hear voices. Is it normal for me to do that? You know, like very simplified approaches. So even when we were doing we're still doing that. Like every month we focus on a particular topic and we're exhausted. You know, it's like if it's depression, we'll talk about, you know, the signs and symptoms, talk about what to say to a doctor when you get diagnosed with depression, how to talk to your friends about it, how to help yourself or how to help someone who, you know, is dealing with depressive symptoms. Like, you know, we explore all of it, right? That made it easy. That I think that probably just made it like it made people understand how serious we were about. First of all, how serious we were about what we were doing. Secondly, it made them much more open to having conversations about, like, you know, because they could see things that were helpful to them and what we were sharing. Right?
Absolutely.
Even if at the time they were not open enough to identifying with the cause, it was helpful anyway. So that's basically when the conversation started. So we started with awareness, but at some point, I sort of realized that the more we did awareness, the more people told us, "Oh, you've told me what is wrong with me. Where do I get help?" We're clueless. You know, it's like, how do we solve this? Because the unintended consequence of too much awareness, or even doing awareness of any kind, is that people will look for how to get help. And if you don't tell them where to get help, it's a reverse stigma. It's like it makes them hate the conversation more. It's like, okay, you told me about this, and you're saying I have it. Okay, where do I get help? I can't get help. Like, how does this contribute to, like, how are you contributing to my health, you know, in general? So March 19, 2017. Before then, we started training listeners.
Training listeners, right?
Yeah, so we call them listeners. Like,
okay.
So basically, we're training them to provide counseling support to anyone that needed support. So we're doing it over phone, and it was basically me and my friends for the first month. For the first month, during that time, we were training others. So for 5 of us, one person was going to train 5 people every month.
Okay.
Now those 5 people will train 5 people. So basically, that's how we started the listening. So we did the listening thing for about 6 months, but we were keeping the data. A number of people calling us, their gender, their age range, and we found that 85% of people that were reaching out to us were women and girls.
Okay.
And 15% men and boys. And I was like, this doesn't look balanced, you know, in any way. So I started reading again, like, how do we solve the problem of getting men to speak up more, to reach out and use the service that we're using, that we're sharing. And I saw a research somewhere that said that, and it was not really like, you know, it wasn't that kind of research where you see like conclusive evidence. It just said there's a liquid chance that men are more likely to text.
Oh, interesting. Okay.
Than they are to call about their mental health. So we just switched. We wanted to test it for a month. The first month we tested it, we had a 25% increase from men and boys. So basically we had a 60-40 eventually, like a balance of 60-40, you know, female, male. And then that changed. It didn't change. The extra outcome of the extra consequence of that was that we had overall a 200% increase in people reaching out to us. So it blew up.
Wow. Okay.
So we realized that now that is the approach that we should use. That basically changed the way that we operated. We moved the call listening crisis. We moved the call-based service to a crisis service. So if someone is dealing with a suicidal attack, or suicidal urge, they can call us. But if you're non-suicidal, but you have ongoing, issues that are stressing you out that you wanted to chat about, you can go and text about it. So that's essentially how we set up our text-based counseling service, which is probably the biggest, counseling support center in Nigeria, because over time we've provided the service to more than 40,000 people and counting. It increases year by year. So that's basically how some of the core programs that we do were set up. Sometime down the line, I started reflecting on myself. I was like, maybe we should change our approach. We keep talking about stigma. I started reading about what, like you, when you mentioned, like, you're very, I wouldn't say controversial in a way, it's like, but I am in so many ways. So I was like, I don't think stigma is a problem. I think stigma is a consequence. Stigma is not the problem. It's not. Stigma is the consequence of a particular problem. It's the consequence of a lack of literacy in mental health, the consequence of lack of, government investments in mental health, the consequence of lack of access to mental health services in communities where people can access them easily, right? It's not something that just came out just because, like, something caused it. The reason why people fear, people that come up with, psychotic symptoms, because you don't understand what it is. It's like, if something is a mystery to me, I don't learn about it or I fear it. It's normal.
This is true. Yeah.
So I was like, yeah, stigma is a consequence. I came out again. I told, it was in a conference, and I told him, like, I am not going to talk about stigma anymore.
Okay.
Now I'm an anti-stigma advocate.
I love that. And I really love what you said. Stigma is not the problem, it's a consequence. Yeah. So tell me more about what you said about that meeting.
Yeah, so I came out, I was like, right now, no one should tell me, oh, anti-stigma advocate, Victor Ugo. Was like, no, I'm an anti-stigma advocate. Now I'm pro mental literacy. And I think I realized something about stigma is that stigma is a negative connotation. It pushes people away from the conversation. Like,
yes,
if I want to talk to you and it's like, oh, like, instead of saying, if you say something that is wrong or something that is not, let's say I say, oh, I've got depression, you say, oh, come on, get over it. If you tell me that, instead of saying, oh, you've got, you're promoting stigma, I would say, in my head, I was like, that's because you don't know about depression, right? So what would I do? I would educate you about my experience of depression, give you links on what to read. And most times, and this is exactly what has happened in Nigeria since we started doing our mental health literacy programs, is that people's knowledge of mental health and mental health conditions have increased. And the more the knowledge increases, the less likely that they would still promote stigma in any way. It's the same with the media. It's like when the media was pushing conversations, they were saying committed suicide, when they were, very, very discriminatory, like, write-ups about suicide in Nigeria. When we called them out on it, they removed the articles, but we didn't just call them out. We put out a guidance on how to report about mental health or suicide. So that's like, it's not just saying, oh, don't do that. It's about, okay, do this instead of doing that. Yeah, so that's how I saw the stigma conversation. I thought it was very, very, it pushes people away from the conversation, and education instead brings them into the conversation. So our approach changed. So since then, it's just been a case of, constantly learning and relearning and using whatever data that we have to modify the program to fit the population and the context that, we were facing.
Okay.
So that's essentially about me and mine. I think I've probably said more than the question, but
no, that is perfect. And if I had more of your time, I would let you speak and write dissertations about it. But something that really struck me about that is how, one, the humility to use your story as a tool for advocacy and the bravery that comes with that, but also this recognition, I guess, through the process of, like you said, co-learning, co-developing, relearning. this recognition that focusing, the framing is so important, and how increased awareness itself is not enough, because increased awareness, like you said, can have unintended consequences, and it can cause damage. And this is something I'm really keen to explore, how in this space of health promotion, advocacy, activism, we unintentionally cause damage by how we frame individuals and communities. So I love that you just brought that up. And so this wasn't even prompted. I love that. So, okay, you shared a lot about your background of M.A.N.I, touched on many things, and in particular, spoken about, I guess, the inception of how you developed your use of technology, so sort of pivoting from the sort of crisis calls, recognizing your clientele was a bit skewed, and then reaching out to figure out how else can we do that. So one thing that's I'd be interested, and I think the audience would love to hear more about, is how has that changed or pivoted during the COVID-19 pandemic, how you communicate with your clients, and if it has, why?
I think we were well set up for the pandemic. I don't know if there was any organization that was better set up than we were, because most of the services that we're offering anyway, like especially for the services that were focused on people, trying to get better, and people trying to deal with stress, and people needing someone to talk to, they were basically digital. All of our counseling services happen online. We have never, and probably we will never do any physical, sessions.
Okay.
That's for counseling and crisis support. So when the pandemic started, I think sometime in March, when we had lockdown, or we had signs. The first case came into Nigeria in March. Then we had the signs of the lockdown. And then sometime in April, the lockdown was much more expanded beyond Lagos State. We had a 75% increase for the first month of number of people reaching out to us, which was manageable. But again, that went crazy, we had more people, I'm not sure I can, more than 200% increase. But the thing is, we're seeing an increase in the number of reaching out to us, but we're seeing a decrease in the number of counselors that we had, because they were also Nigerians. They were also experiencing the pandemic, right?
Yes.
So it was a very difficult time for us, because even though we were set up for it, we still found it difficult to cope at times, because the number was too much. From 40, it was when people reach out to us, they say, I'll reach out to you in 24 hours. But from 24 hours, we went to 5 days. Wait time. And that was not funny, because people will say, oh, you said you're going to reach out to me. You haven't reached out to me. Okay, don't worry. It's like they try to guilt trip you to say, you guys don't care about me. You said you care. You come online and post that you care. But
that must have that must have been difficult. That must have been very difficult. Yeah.
It was so difficult, So we had to start training more counselors. So we were losing some, we were getting more. So we had to put in more effort into training more people. But September, October, NSAS. That basically wrecked the system that we built. We had to get external support, because then it's not a question of our counselors leaving, it's a question of them saying, I'm exhausted, I'm overwhelmed. I can't be talking to a client when I'm dealing with this. So we had to get support from South Africa, from the US, from Canada, some of our partners. We had to set up a whole system for us to be referring cases to them. And cases where our counselors needed that support. Our counselors and our volunteers and people already within our own community, we had to refer it to them. That was the only way. It was a difficult time, but it was the only way that we could actually cope with that. So it wasn't just the pandemic, it was the pandemic, it was the lockdown, it was the time after the lockdown, which was so uncertain. And it was then, NSAS and the police brutality and all the things that happened during that time. So I think 2020 was one of the toughest years for us. We in fact, what happened from January 2020, once we found out that the pandemic was a public health emergency, right? We actually stopped all our offline and physical programming, because I think when it comes to my paranoia as someone who has been a clinician, who understands, who has read a lot about pandemics, I used to read a lot. I don't know why, about the Black Plague, about the flu, Spanish flu. I read a lot about a lot of papers about it. So it felt like, just remembering how that went, I was like, we're not going to be the reasons why people will actually come out and get infected. And we didn't want to lose anyone. So while it was a difficult decision to do, we actually had to pause all our offline programming. It was a lot. We had school mental health programs that were ongoing. We had workplace mental health programs that were ongoing. We had communities across different states where we had chapters and people coming together to have conversations. That was the end of it. Until today, we actually haven't come back to those chapters and probably will never do that. So it led to the change of model eventually. Now we changed the model for how we operate. But in a way, like I said, we were set up for it, but we were not prepared for the extent of the gap that we were feeling. Like, we didn't know how much of a gap that we were feeling when people started experiencing more mental health conditions. And it showed us, I think it showed us the importance of going beyond being a nonprofit that just provides services. And I think I wrote about that recently, because we just finished our 5-year strategy. It changed the way that we wanted to operate, from just being a service providing organization to a core advocacy organization with a service provision as an added perspective to what we do. So we want to do something more sustainable, like going to the government, establishing relationships with them, promoting actual policies and plans that are long term. Because I tell people, nonprofits are great, but they're not sustainable. They're like, they're not something they're not scalable as well. It's like, what the nonprofit should focus on doing is to get, first of all, test the program, test what it is, the intervention that you're doing in a smaller scale, do a direct advocacy with government and decision makers. And if it's a proper program that has the data, that has the evidence to show that it works, advocate for them to scale across the community. They have the resources, they have the money, they have the power, they have the political will, right? To get it to scale. But a nonprofit could never get a program to scale. It's impossible. It's not sustainable. Even if they did get it to scale, it's probably going to last for a year and it will end. So many nonprofits in the mental health space, even in Nigeria, we don't have so many nonprofits in mental health space in Nigeria, but even for those that exist, a lot of people focus on the program, let me do a project, it's probably for 1 year, let's get funding for it, let's get it done. But what happens after?
This is true.
We don't think about sustainability. So the pandemic gave us a lot to think about. The positive from it is that we are very confident about the approach that we've taken. We're very confident about the strategy we're going with. We're very excited about it as well. Like we have changed quite a bit about what we're doing. But I think the other outcome was that we saw the need to automate our services. So we're going to be in a couple of months, maybe in 4 months, we're going to be launching a digitalized counseling service. It's not going to be an app, it's going to be integrated into WhatsApp. So you don't need to download anything. You just need to go scan the QR code or text a particular WhatsApp number, and you will be connected to a counselor very easily without having to text us on Instagram or Twitter or anything like that. And one other thing it's going to do is that it's going to help us establish the evidence base behind the incidence of mental health in Nigeria. So because we'll be screening everyone that actually uses the platform, every month, if we have 1,000 to 3,000 cases across Nigeria, it can give us a good picture of the state of mental health in Nigeria. So every month we're publishing a state of mental health in Nigeria report, sharing this number of people reached out to us, this number of people that have anxiety or depression, but we're going beyond that. And that's why I find your question interesting in terms of how digital mental health solutions and how digital affects mental health. And that's because we the positive that we are saying is that if we can do that effectively, we can actually connect it to, say, Twitter. If we connect it to Sentinel analysis on Twitter, which tracks hashtags and it's like ongoing analysis on Twitter, we can connect spikes in anxiety or depression or in other mental health symptoms to particular hashtags or particular policies that were passed, or particular occurrences that happen in Nigeria, and we can make a very huge policy case as to why this policy doesn't work for the social welfare of Nigerians, or this works, right? So we think that even in separating our focus, we can connect them in a way. It's like by digitalizing this particular program that we're doing that is impactful, we can use the data from it to actually directly advocate to governments across different states.
I have never come across a concept like that. Like, my mind is just blown about how it's very clear that you're very obviously mission driven, but also data driven and very reflective and continuously going back to the grassroots to figure out how to get better. But combining that, the whole data driven mission with social media and like monitoring hashtags and matching that to, what is going on within that sort of ecosystem, socially, economically, politically, and matching that to mental health symptoms. I've never heard that. Maybe it's because I'm not an expert in this space, but that is amazing. Have you heard of anybody else doing that? Because
I haven't yet heard that.
It's just a very I think innovative way of collecting data. Wow, that's very fascinating, and I look forward to reading some of the the monthly reports that come out of that. And
no,
wow.
we're excited about that actually, because we want to use that as an entry point for the Institute of Research for Mental Health that we're building. Because that's one of the things that we have in the strategy, is like we want to build an institute for mental health research. It's really focused on young people, but actually it's not just going to be focused on Nigeria, because while we're going to launch that next year, probably February, we'll do that for 1 year as a pilot in Nigeria, but we're actually going to be scaling across Africa.
Okay.
And the perspective is that we will probably engage with other mental health organizations and support them in the training of the counselors, and eventually, give them we would have built the tech and the data part of things. We'll just give them the package to do in their own countries. So basically, like a franchise that they can make it easily scalable. So we're not just building for the sake of it. We're building for something that would scale across Africa and can be like a case study for other low-income countries as well. Doing something similar, maybe.
Yeah, I think that's very clever. And also, I love what you said about how, so some people would actually argue with you that NGOs can be sustainable. But I think your point is very strong about how perhaps that's not the function. The function is to be the platform and the strong community-rooted advocacy base that also provides the test of concept, right? That other partners can scale up with. And I really appreciate what you said about how, particularly with the stress of the pandemic on your workforce who were helping the community, you reached out to partners, even outside Sub-Saharan Africa, it sounds like, to give you that support. And wow. This is very fascinating and just very, very exciting to hear about. And also, it sounds like, because, we spoke about how there's this controversy about the impact of screens and like digital technology on mental health. Now, obviously, you said you felt like M.A.N.I was actually pretty well set up for the pandemic, but obviously during the pandemic, and in particular, adding on what was going on in Nigeria with SARS and police brutality, you had to pivot. Do you experience from your clientele any issues in terms of this? Because, you're basically interfacing with them purely digitally, like you said, not very much in person. Do you feel like that is a problem? Have you had clients who are finding that difficult? And if so, how do you overcome that? Because this is a big debate. But I'm thinking particularly because, in recent times, you've seen scandals like many of us knew about with regards to what was going on with Facebook and how there's concern about how there was evidence about how social media, digital technology was negatively impacting, for example, teenage girls' perception of their image, ties very closely with mental health. So that's just one example. But I just wondered, have you seen any challenges of your mostly digital model?
I haven't. I think one thing that people like to exist in, there's no middle ground for most conversations and arguments. It's always it's like either black or white. There's no gray. But I like to exist in that little middle picture.
Yes, I'm very much a gray person, so I echo you.
Yeah, so I think that social media has pros. I also think that it has cons. Like, I think that social media companies, their business and like they're doing things to make money, which actually are harmful to people. But the social media itself has its own positives in terms of the way that it enables connections, the way that it makes it easy for people to access things that they would typically not have access to. We can't deny that that's the case, right? So I'm just right there in the middle ground, having this, like I've seen those papers, I've seen those research, I've read them, and I know for sure that they have that effect on people. But the question I usually want to ask people is, it's not going to end. This is a social media, this is a digital age, right? They're not going to shut down. What we need to do is to find a way to have the conversation about reducing those harmful actions, but also providing the solutions for people in the same space where they encounter the harm. So we have a partnership with Origin that talks that
Origin, right?
Origin Global is in Australia. So it talks about how to have safe conversations online.
Right.
So the name of the program is Chat Safe, and we help to adapt that particular manual or guidance. It's an online guidance to Nigerian context. So it talks about how to have safe conversations about suicide, how if you're having suicidal symptoms, you can actually talk about the symptoms you're having. Because the thing is, people would naturally just have those conversations. We're now trying to say, okay, this is how to do it in a safe way, right? So Chat Safe actually is a very expansive tool that would help people to have those safe conversations. What we also do, even with our Chat Safe, is if you want to reach out, like if you're online, if you want to reach out for your mental health, these are the things that you can reach out for your mental health digitally, right? But also, if you find someone on your space, and this is something that we did very much at the beginning of when we started the counseling center, was that we pushed so much for people to be spotters. You know how if you go to the bridge in California, that people usually, in some sense, people usually jump over the bridge. I've
heard,
right?
Yes.
The way that they countered that, the way that they tried to counter that was to place spotters. It's not just in California, in China, in I think in Australia as well. Like they put spotters. It's basically the job of those guys to spot people trying to jump. So we thought, like, okay, this is the digital age. People no longer write suicide notes on paper; they write it online, right? And if we can find people before they take the jump, they would have posted, "I want to kill myself" online. If we can find those posts before they actually go ahead to kill themselves, then we tell people what to do. And if you don't know what to do, just tag us. So if you go on Twitter, we are constantly tagged to people people actually voicing their distress, or I can't take it in anymore, or I'm tired of this life. It's at mentally NG. Because we made people do that, like we made it like a conscious thing. We put it in a course, like if someone is having these thoughts, please just tag us to the tweet. So we identified those people as spotters, just like we have the spotters on the bridges. And the bridge in this case is social media. Like basically it's the suicide note. Social media became the new suicide note, right? So people were typing, it's like anything happens, it's not going to stop. It's expanding. We have the new generation. It's like you find 9-year-olds who are so conversant with social media. You can't say, right, don't do that or don't go on there, because that's where everyone is. That's where all their friends, that's where they have all of their friends. That's where they have all the interesting things that they identify with as a generation. So I don't think it's a question of fighting social media or trying to shut down social media or trying to vilify social media. It's a question of saying, right, we know that it is harmful in this number of ways, but we are creating solutions in this number of ways to counter it. Now, this might seem a bit contradictory to my, look for the root cause thing, right? But in this case, social media is massive, it's huge, it's a generational concept that we can't throw away. So we just have to find ways to adapt, like we do in every situation, and make sure that people actually exist in that space in a safe way.
Wow. Thank you so much for sharing that. And I really, the image you created in my head as you described, social media as a bridge, and literally you have created this army of digital spotters to man this bridge, right? Wow, that is very, very insightful. And I also really like how, because I think you're right, we cannot hide, we cannot run from social media, we cannot run from this digital age. I think this year, this year, the theme for the International Day of the Girl Child is, the digital generation, our generation. And, that's particularly why I reached out to speak to you, because I'm very aware of M.A.N.I's background and, what M.A.N.I's doing, and also very aware of how you and M.A.N.I occupy this controversial space in terms of social media and digital tech. But so it's very insightful for me, and I hope our listeners to hear about how you pivot this and how you sort of just, face these challenges head on and like grow and get better with it. So, wow, I wish I had more time to speak to you, but I know we have to bring this to a close. You know me, if I could, I would just talk. So I'd like to end with, I guess, two more questions. First question would be, so you obviously focus on young people, and which, encapsulates sort of what I'm sort of focusing on in this month on adolescents and adolescent mental health. So it's very important. Do you, from your perspective, as an expert, as an activist, and somebody who actually, has a history of mental health, somebody who has used their story to push this, somebody who is passionate about this space, do you see any gaps when you speak to different types of people? And in this case, I'm putting a mirror to myself, somebody like me who represents reproductive health. And when people say reproductive health, we do tend to think of girls and women, but it includes everybody, whatever your gender or sex or sexuality is. So are there any gaps you see when it comes to mental health issues in terms of how you intersect with your clientele when it comes to reproductive health? Is there anything you would like to say to people like me, so reproductive health advocates, reproductive health policymakers, reproductive health clinicians who are clinicians like you in terms of your background? What are we missing? Because I know it's a lot.
I think, we live in a world of labels, right? Like everyone has to identify with a particular label. And that's divisive in its own ways. Like I'm in reproductive health, I am in mental health.
Yes.
I mean, addictions. So I mean, it's like everyone just chooses their own, which is nice, like it helps you focus. But I find that all of the issues that we deal with are so intersected, like in a way that it's real. Like if you go down to a community, you will find that most people would present with all of those issues. Like most young people, especially, like when they come of age, they're dealing with questions about their sexual health. They're dealing with resilience, how to identify, how to build their own coping mechanisms and resilience, with peer pressure and all of the things that actually come with mental health. And if you look at the difficulties and the predisposing factors to both sexual health disorders and mental health disorders, they're just right there in the social determinants of health. Like it's poverty, It's poverty is like poverty makes it unlikely for a girl to be able to afford pads, right? It's also the social system that doesn't provide that for them. But it's the same thing for mental health, and it's crisscrossing across all of these issues, right? So I feel like when we exist in those silos and we don't come together to work, it becomes difficult to create sustainable programs that actually affect people holistically. It becomes very difficult to create those. And that's why we have, that's why we have a lot of issues, I would say, in places, in structures and systems that are not strong enough, like in Nigeria, or using the example,
yes,
where we don't have a very good primary healthcare system. Even though it exists, we have if you look at our health system, it actually is it's actually a nice system. It makes referral easy. It's like if you're a parent in the primary healthcare center, you present with issues that are very, very easy to deal with. Which is why you find community health workers, you find nurses at that level. If you go to the secondary healthcare center, you find non-specialists, right, who can prescribe and who can handle not necessarily serious issues. And then if you go to the tertiary healthcare center, you can find specialists who focus on the more severe cases. Now, this system is set up in a way that it's set up so that we don't crowd out the tertiary healthcare center. But it's not working because, first of all, we don't have enough primary healthcare centers. We don't advocate for it. We don't have enough investment in it. And it still comes down to the same issue of, it's like people working in silos, right? So I feel like, and this is an approach that, we are taking in, if we're trying to do research soon on the language of mental health. And we
Right.
thought, if you're doing this research in a typical way, we'll just probably engage psychiatrists, right? But we're not doing that. Actually, the core group that we're engaging, they're social scientists, they're computer scientists, they're, it's like engineers. They're design thinking agencies. We're trying to move away from the typical scientific structure for research and do a much more community participatory approach. That way we can understand all of the problems that people will present with. Because sometimes people present to the hospitals with, like, should I say, symptoms that are not necessarily mental health symptoms, but they're somatizing. They're basically like they're coming with physical manifestations of the things that they're feeling internally. And it's difficult to identify for people that do not know that people can present that way. Which means that we constantly miss mental health issues. And this is very common. Just going back, this is very common in adolescents. And there's a problem that I see. It's not just in Nigeria, even in the UK. It's a missing gap for care in mental health for adolescents. It's either child psychiatry or adult psychiatry. There's never really a specialist for it. The way they combine is like child and mental health services. That adolescent one is an and. It's not necessarily given as much focus and attention as the other one. So when you find adolescents who is transitioning into adulthood or who is between that transition, they actually don't know where they fall in. They don't have the right classification for those their age or those in their age group. So it's very difficult to actually cope as an adolescent when you have a mental condition. So for people in sexual health, I would say that, for most of the programs that you guys, I would say you guys that is done by sexual health experts, even in, what's that called? I forgot. Adhering to medications. Let's say HIV, for example. Like mental health plays a very key role in that, even in those like in sexual practices. We know about how some of the symptoms of bipolar disorder has hypersexuality. And, there's that intersection there, like, what about safety at those times when someone is hypersexual, right? Like, so there's a clear intersection, but we constantly try to find a way to divide them, So, it's not something that I'm going to fix in one day, or it's like we are going to fix in one day. But I feel like these conversations that we're having within the younger generation of practitioners and clinicians, and even non-clinicians and researchers, they need to keep happening. We need to keep on exposing ourselves to new knowledge, exposing ourselves to new concepts, and actually talking to people in other fields and other spaces to learn how their work is going, to learn how we can integrate ourselves into their work. And that's why I think the last thing I'm going to say is like, that's why we need to be talking about how to integrate mental health into the universal health coverage conversation, because apart from the increased funding that's going to come with, it also opens up conversations about how mental health relates with every other health, physical health manifestation or concept. But that's something we're a long way off, from achieving in Nigeria. But hopefully, someday we can actually get there.
Thank you for sharing that. And I think what you did just there, I was about to ask you, like what you want to say to the people listening in terms of policy and the future, but you summed that up like perfectly. And yeah, thank you so much for, spending this time with me and, giving us, an understanding of your background, Manny's background, but also how you have pivoted within the space. Bearing in mind, you were very prepared for this time, being digital mostly, and also sort of for forecasting how things might look in this space and highlighting, I feel like the things you really were keen highlighting was the importance of the framing and the language and the importance of these intersections and the importance of avoiding silos. So thank you very, very much for that. It's been great spending time with you. I wish I could keep chatting, but I know it's because I think you're 6 hours ahead of me or something like that. So
I am.
Yeah, so I know it's past your bedtime, but I really appreciate this, and thank you so much.